in corneal diseases and improving outcomes. Oh, sorry. Excuse me. These are my financial disclosures. None are relevant to the presentation. So what do patients want? Well, it's actually very basic. Next right here, thank you. Patients want great outcomes and safe procedures, the same thing that surgeons want, and so we're all on the same page with that. What about patients with corneal disease? Just because a patient has corneal disease does not mean that they don't deserve a good refractive outcome. They may not be idealized as somebody without corneal disease. However, they still deserve the best refractive outcome possible. It's not just enough to have an anatomic success. We should have a visual success as well. Taking patients with keratoconus, for example, when we address patients who have keratoconus and do cataract surgery, one of the main things is to also address patient expectations. You want to look at the topography and tomography, take a look at the cataract, the density of the cataract. Usually we do the cataract surgery first, but there are cases where in a younger patient you may cross-link the patient first. And it's also reasonable to consider a toric lens. Now, how do you decide? I get patients sent to me all the time, and they have keratoconus, and so people are asking, when should we do cross-linking? You know, when should we do cataract surgery? And I would say that if the patient has mild keratoconus, there isn't, or even moderate keratoconus without documented progression, you can easily do the cataract surgery first. However, if you have a very difficult refraction, you're not getting good K readings, then you could do cross-linking first. Cross-linking to stabilize the cornea, but also to get a little flattening. Reasons for treating older patients with cross-linking? Of course, it's to prevent progression. You can still have progression in older patients, but it's also to improve irregular astigmatism and obtain more consistent K readings. This can allow you to decrease or flatten the K readings to allow a better contact or spectacle corrected vision. This is an example of a patient of mine, a 60-year-old, yes, 60, with keratoconus and had documented progression when I saw them a year later. Another patient, 47 years old, again, here was the initial tomography. The second is this is progression before cross-linking, and this is about 9 months post-cross-linking, and you could see that there was, in fact, a flattening effect. Well, what about toric lenses? How do we decide what kind of toric lens to place? Toric lenses are possible to reduce cylinder in keratoconus patients with cataracts. They will not eliminate the cylinder, but we can certainly give them an improved outcome. IOL formulas are very important. The Kane formula is a newer formula that I think is very helpful for keratoconus. You also want to plan on some myopia. I usually aim for about a -1 to a -2, and you of course need to set expectations. The Barrett-True-K formula and some of the other formulas that we commonly use, I find have a little bit more variable results. Let's see here. There we go. IOL marking for toric lenses, even if they have previous intrastromal corneal ring segments, you can still get a good result with a toric lens. And this is an example of placing manual toric marks there on the cornea. Very, very easy to do. You really do not have to and should not consider removing the ring segments and can again use toric lenses. How about ocular surface disease? Well, we all know, we all see patients with pterygia, basement membrane disease, dry eye, Salzmann's, and of course, we want to optimize the ocular surface first. You can see here in the pennicam below and the clinical figure above, this is a patient with Salzmann's disease, has a Salzmann's nodule, and you can see right there, very similar to when you have a pterygium, that area of flattening. So this is important to optimize before you consider cataract surgery on the patient. With pterygia, I usually wait about 6 to 12 weeks after excision, and I do a pterygium excision with a conj graft, and then I wait 6 to 12 weeks and then perform my biometry. If it looks a little funny, you can always keep up dry eye treatment afterwards, which all pterygia patients should have anyway, and then repeat the biometry. With basement membrane disease, Salzmann's nodules, I perform a superficial keratectomy, peel off the nodules, get rid of the offending basement membrane disease, wait 4 to 6 weeks, and again perform biometry. For people who don't think that dry eye matters, here's an example. This is a patient who had previous LASIK and had dry eye disease, and you could see that if I went with the IOL that I calculated before several weeks of dry eye disease, I would have implanted the wrong lens implant. So dry eye disease matters. Astigmatism. You need to look at the astigmatism and decide, is it regular or irregular? Even with some cases of irregular astigmatism, such as keratoconus, for example, you can still obtain a good result with a toric lens. Sometimes, though, it's too irregular, and then a toric lens is not going to give you what you want. The usual rules with astigmatism apply. Undercorrect with the rule, fully or overcorrect against the rule, and also remember about posterior corneal astigmatism. Well, if we're going to talk about astigmatism, we need to know how to measure it. I say to choose more than one diagnostic method, be consistent, compare your readings, and again, of course, if there's corneal pathology or ocular surface disease, read that, address that first, and repeat the readings. There's all kinds of devices, diagnostics that you can use to measure astigmatism. In my own practice, I have an IOL Master 700. I also have a Penacam and a Cassini, and I actually use all three devices. You need to make sure you mark the axis, and there's a whole variety of ways you can mark the axis. Manual marking, you can use digital marking, you can use intraoperative aberrometry, which I have found to be a bit less useful, and femtosecond laser. I have a LENSAR laser, and with the LENSAR laser, I really like it because you can get these nice little custom capsulotomy with little notches or nubs in the capsule. You could see here that for a standard toric lens, it will easily align. Even in a case, for example, of a toric lens with a lens coloboma, and the reason for those crisscrosses is because it is a denser cataract. And also in the case of RK, I routinely put toric lenses in RK patients. When it comes to astigmatism, again, optimize the cornea before the cataract surgery, choose at least 2 pre-op diagnostics, undercorrect with the rule, fully or overcorrect against the rule, mark the axis, align the IOL, and if you do have IOL rotation, then I wait 2 to 3 weeks before realigning. What about cataract surgery with endothelial compromise? Well, this could be patients with previous full thickness PKs, previous DMEX or DSEX, Fuchs dystrophy, or other posterior dystrophies. And the question also comes up, do you do a combined procedure? Do you do the cataract first? Do you do DMEC or DSEC first? And I think that you, again, just like with keratoconus, you need to really evaluate the whole patient. You need to take into many considerations. If the patient is at or above the age of about 50, all of the literature shows that you should really consider a combined procedure because chances are they're going to need that cataract out within a year or two. If there's just guttata or corneal edema greater than the cataract, you can do, I like doing a DMEC on these patients, usually a younger patient. You can get a nice result with a DMEC and then proceed with cataract surgery later. And if there's, of course, not too much endothelial compromise, you can consider cataract surgery first. In the case of other corneal opacities, dystrophies and such, I really like to try to do my transplant first. If it's a full thickness or a DALK, I will do that first for improved visualization and improved K readings. When you get to doing the cataract, you'll get a much greater accuracy of IOL calculations and actual versus estimated K readings. Let's see here if, oh, there was a video there. Here we go. This is femtosecond laser-assisted cataract surgery following a cornea transplant, and as you could see by the pattern, this was actually a very dense lens. I use a dispersive viscoelastic to protect the endothelium. I do aggressive hydrodissection and hydrodelineation. You could see the bubbles there from the OVD that I used from the dispersive, and I use a soft shell technique for that. The nice thing about the femtosecond laser is that it basically pre-chops your cataract, and therefore removal becomes much, much easier. Let's see if this video will work. That video doesn't appear to be working. There we go. Now it is. Okay, this is a patient again with a less dense cataract. This was following a cornea transplant, at least a year later because I like all sutures removed. Again, I do a soft shell technique, and for this patient who had a significant amount of astigmatism, you can see the corneal relaxing incisions that I placed with the femtosecond laser. You could also do this manually if you don't have a femtosecond laser. There I am aligning a toric lens, aligns really, really nicely, again, with the corneal relaxing incisions with a transplant. We know that corneal endothelial loss following femtosecond laser-assisted cataract surgery, there is a decrease in the endothelial cell loss, and that's a really nice thing if you have that available. It actually causes less corneal edema in the early postoperative phase, and again, less endothelial cell loss, which is really helpful for patients with either endothelial disease or with a previous transplant. What about cataract surgery with refractive patients with previous refractive surgery? Well, once a refractive patient, always a refractive patient. So these patients have very, very high expectations. Patients with, we're seeing more and more patients who previously had ICLs, phakic IOLs, patients with, of course, laser vision correction or RK. This is a patient who had ICL, and how I like to remove them, I know some people just orient them and pull them right out. I actually, just like a regular IOL, I just cut it, not apart, but I just make different cuts in it, and then I just twist it out. And again, the same sort of method used here with hydrodissection, hydrodelineation, use of additional dispersive viscoelastic. I always do a bimanual technique, both for my phaco as well as my IA. And then you can place a toric lens or a EDOF lens or whatever you like there. In the case of a cornea transplant patient, I don't use any multifocal or EDOF technologies. Cataract surgery, of course, is refractive surgery. IOL calculations can be challenging. For my regular patients with previous refractive surgery, I tend to use the Barrett-Trouquet formula. I find that works best in my hands in my clinic. I like getting the ASCRS formula. That they give you a whole bunch of formulas, and you can take a look at that. The Kane formula, again, I really like for keratoconus. And of course, there's different IOL choices these days. One thing that's really important when you have a previous refractive surgery patient, especially someone who had LASIK or PRK, is I really like to look at the holiday report on the Penacam, looking at higher order aberrations and also chord length mu. Chord length mu relates to angle kappa. And if you see, and it's really nice because it's red, so it's red, stop, right? If you see a lot of higher order aberrations, as you can see here with the horizontal blue arrow, then you really do not want to put a multifocal or trifocal lens in that particular patient. Chances are they're going to be unhappy. You can use some of the EDOF technology. You can also consider an IC8 lens, the small aperture lens as well. Cataract surgery following RK, again, avoid the multifocal IOLs. You may need to suture the wound and or the previous RK incisions. Sometimes you have to do a scleral incision, and sometimes the incisions start to flap up, and it's a little bit exciting. The thing that's newest in my practice is I've started to use the light adjustable lens. The LAL can adjust up to 2 diopters of astigmatism and plus or minus 2 diopters of myopia or hyperopia. It works by having selective macromers on you do these light treatments afterwards. And so you want to still get as close as you can to where you want to be, but the nice thing is you can really customize it to the patient afterwards. You get 4 shots on goal, essentially. You get 4 treatments. I aim for plano in the dominant eye, and you do get a little bit of an EDOF effect in the non-dominant eye by aiming for at least a -0.5. And it's really impressive. These patients actually get more range of vision than you would expect with just aiming for about a -0.5 refraction. So in summary, cataract surgery in patients with compromised corneas can still achieve good outcomes. You can provide refractive benefit for patients with corneal disease. Also make sure that both you and the patients are aware of the limitations. Address the corneal disease prior to cataract surgery when possible. There are newer IOL calculation formulas. Try them, see what works best in your hands, with your patient population. And there are opportunities for toric IOLs in patients with all kinds of previous corneal transplants. Thank you so much. It's been a pleasure.